Diabetes is basically a disease process. It starts out with a patient maybe having symptoms of what we call polyuria or polydipsia, where they sometimes feel like they need to drink frequently or eat frequently or urinate frequently. Sometimes it starts like that, but it doesn't always present itself like that. Patients can come in and have lab work done, and we see that maybe their fasting glucose, which is their sugar, is elevated, or we check for something more long-term, which is the hemoglobin A1C. If that's typically elevated, we kind of go based off of that. That's a 3-month average of blood sugar. So there's a few diagnostic criteria in that sense. A lot of times it's genetic, it's familial. Sometimes it can be based off of diet. I have a lot of patients that are pre-diabetic, and their A1C is anywhere between 5.7 to 6.3, then you get to 6.4%, but you have those numbers. And if they're pre-diabetic, it's really about catching the disease state before it gets worse. And a lot of it is about prevention. My patients who are pre-diabetic, I tell them work on their diet, exercise, weight loss, again, very holistic. And then in terms of diet, it's a lot of the carbohydrates. Patients have this thought process in their mind, oh, it's all sugar. I just have to cut out my sugar and I'll be good. But I tell them it's a lot of the carbohydrates too: pasta, bread, rice, potato, white flour. So the next step is more frequent monitoring. Some patients think they just need annual blood work, but a lot of it is bringing them back and saying, okay, we're going to repeat your labs in about 3 months, 6 months, 9 months, 4 months, whatever it is. And we can go based off of more of a trend. I don't like to just treat patients based off of one number and one value. I like to see what's going on behind it, whether it's diet, exercise, and just kind of that trend with the numbers. That kind of plays a big part. There's many different options, whether it be pills or injections. It's really just coaching them about these things and going over all the side effects and how frequently they need to be monitored. And a lot of my patients think, okay, I took the medication, I'm healed, I'm good. And I kind of have to explain to them this is going to be a lifelong process of trying to get your glucose where it needs to be, because in terms of deleterious effects, you can see effects on your kidneys. Diabetes, especially if untreated, are the leading causes of chronic kidney disease, not only in the US, but in the world. Leading cause of blindness, and so forth and so on. You can have microvascular and macrovascular complications. Patients who have long-standing uncontrolled diabetes can develop something what we call peripheral neuropathy. So they feel like they have that numbness and tingling in their fingers and toes. You are unfortunately always going to be diabetic, but we just have to make sure we stay ahead of the disease process, and we can typically nip it in the bud at that point. So this is all having to do with type 2 diabetes. When a patient's A1C goes above 10%, very uncontrolled, they have a risk of developing diabetic ketoacidosis or potentially going into a coma if their blood glucose is extremely high. And then at that point, I'm inclined to send them to the endocrinologist and have them follow up with the specialist at that point. We as primary care physicians handle insulin. A lot of the time I have patients coming to me on insulin, but it's nice to always have that second pair of eyes on the patient that are also following up. And typically I tell my patients this is screened at an annual physical. The guidelines are somewhere between 35 to 45 years old where we start checking a hemoglobin A1C on an annual basis. But my patients who have very strong family history or fit basically the character description of someone who's diabetic in terms of whether or not it's metabolic syndrome, being obese, so forth and so on, poor diet, I try to catch these a little bit earlier. So anybody 18 or over, I tell them, please go see your general practitioner for an annual physical. And basically we start off with the blood work. The most basic blood work you can even do can kind of catch that early on.